Hi everyone, my name is Emma Leacy. I am a PhD researcher and project manager in Trinity College Dublin, and I work in Professor Mark Little's lab. And I'm delighted to be invited to speak here today. This is my second vasculitis patient conference, and I actually attended one in 2017 in a hotel in Dunleary. And it was my first kind of introduction to vasculitis patients, and I learned an awful lot about the disease that day. It was the first week of my PhD. So very much in at the deep end, but I really enjoyed it, and I'm delighted now that I'm able to speak at the conference and tell you a little bit about the work I'm doing. So I'm usually by day a PhD researcher, and I'm researching the role of metabolism in ankylosing. And I was due to start my final year this year, and then worldwide pandemic happened, but it gave us a unique opportunity to investigate the role of COVID-19 in our ankylosing patients, and from this the DeCOmPRESS study was born. And this study aims to define the disease course and the immune profile of COVID-19 in immunosuppressed patients, particularly ankylosing patients. So just a quick disclaimer before I kick off, despite what the program says, I'm not a doctor, I'm not a medical doctor, and I'm not a PhD doctor quite yet. So I can't offer any medical advice to do with COVID-19 or ankylosing. On this forum, there's some people here who can help answer on the call some medical questions, general medical questions, but we can't give any personal medical advice. And the second disclaimer is I actually don't have all the answers. The rate of COVID-19 research is incredibly fast. There's new discoveries being made every day, and it's been a struggle to keep up with this brand new field. I've only been studying it for 6 months, and kind of to highlight the speed of that research, you can see that traditional vaccine development takes about 15 years to go through all the different quality control and regulatory steps. However, COVID-19 vaccines are due to be developed within a time frame of 1.5 years, which is completely unheard of, and it's all progressing very rapidly. So I'll do my best to answer all the questions that people may have if you want to put them in the chat. But I'll do my best. So by now you're probably all familiar with this image. This is a graphic representation of the SARS-CoV-2 virus, and Dr. Clarkson gave a really good introduction to the virus, how it works last night. So it's spread through contact with infectious surfaces, through respiratory droplets in the air, coughing, talking, sneezing, and it enters the body through the nose, the mouth, and the eyes. And then once it enters the body, it travels to the lungs, where it starts to cause problems. And the disease that's caused by SARS-CoV-2 is COVID-19. And the main symptoms of this disease are a fever, a persistent dry cough, and shortness of breath, among others. Because this disease spread so rapidly and was quite severe very quickly, the Irish government issued a lot of advice very quickly to try and protect the health of the Irish people, and particularly it targeted some what they called extremely medical vulnerable people. And ankylosing patients, they kind of fit under this term of extremely medically vulnerable for two main reasons. The first is that a lot of our patients would take immunosuppressive therapies, and because their immune system is repressed, it leaves them more susceptible to infections. And also that the majority of ankylosing patients are age 70 or over. The average age of onset of vasculitis is 68 years. So for these two key reasons, the Irish government advised ankylosing patients to take additional precautions. I just have some evidence here. So just saying that those severe infections are more common on people taking immunosuppressants, particularly pneumonia, which is a lung infection, is a more common complication in ankylosing. So our patient population were advised to take more precautions, but despite that, the risk factors of COVID-19, the severity in these patients with vasculitis are unknown, and it's difficult to determine what these are given the rarity of ankylosing and other disorders. So our team wanted to kind of understand a bit more about that, to understand a bit more about COVID-19 disease in vasculitis patients, so that we could develop the advice a little bit more and probably give some more reliable information to these people. And the DeCOmPRESS study was born from this. So you've seen this graphic earlier today. It's born from the strength of the rare kidney disease biobank. So we have a lot of nationwide centres, and we've recruited nearly 800 vasculitis patients to date who donate their samples, thankfully, to the biobank, and they're all processed in our lab in James's Hospital in Dublin. So given that we had a large group of patients who were willing to donate those samples and happy to work with us, we were able to then study the effect of COVID in these people. This study is funded by the Health Research Board. The study is also designed in line with the Global Rheumatology Alliance, who are studying COVID-19 in autoinflammatory disorders and rheumatology patients. And all of the data that we collect as part of this study is in line with the Go Fair initiative. So all of this information will ultimately be publicly available with no identifying information at all. We don't collect any identifying information in the course of the study. So the study methodology, we are looking to recruit patients who have been previously diagnosed with vasculitis. That's the patients in the rare kidney disease biobank cohort. Cohort is just a group of patients. And then of that group of patients, of that RKD biobank cohort, we want to examine the ones who develop COVID-19 and recruit them into the DeCOmPRESS study. And the main question we're trying to answer is, what is the effect of different immunosuppressants on the disease course of COVID-19? Because these patients with vasculitis will have been taking these immunosuppressant medications before their COVID-19 infection, and what is the effect of those drugs on the COVID-19 disease? We collect a lot of different information on these patients, a lot of the detailed clinical data, that would be collected during a routine clinical visit. We collect that in a software called REDCap. We profile the different immune cells that you have in your body to see if their numbers are changing or if they're becoming more or less activated and what type of proteins they're producing. We look at different inflammatory compounds in the blood to see what is the systematic effect of the disease in these patients. And then 3 and 6 months after the initial COVID infection, we collect some more blood samples to look at the antibody response. So how different antibody types have developed over time and how those are different from people not taking immunosuppressants. So for the purposes of today's talk, I'm going to talk about the whole UKVAS cohort, which is a pooled kind of resource of vasculitis patients in the UK and in Ireland. And there's a lot of overlap with the DeCOmPRESS study and the UK study, but I'm going to focus on the kind of shared resources and the overlap today. So to look at the kind of patient cohort, the characteristics of the group of patients that we were able to examine, this was a group of 65 vasculitis patients who developed COVID between March and July of this year. 7 of those patients were in Ireland and 58 were in the UK. The average age of these patients in this group was 70 years old, and there was an even split, roughly even split of male and female patients in this group. When we look at the types of vasculitis that these patients had, the majority were ANCA positive. There were just 15% had non-ANCA associated vasculitis. There was a roughly even split then between the ANCAs of MPA, the MPO positive vasculitis, and GPA, which is the pure 3 positive vasculitis. And the remaining 9% were EGPA diagnosis. The 3 most common types of medications are listed here. There were corticosteroids, as Dr. Clarkson and Mark discussed earlier. Rituximab, which is an antibody depleting therapy. 33.8% of patients were taking that. And cyclophosphamide was the next most common medication type, which is another broad spectrum immunosuppressant. And there were other medication types that less than 10% of patients were taking as well. So when we look at what types of symptoms that our vasculitis patients experienced with COVID-19, we didn't see a lot of huge differences initially. The fever, shortness of breath, and persistent cough were the most common symptoms. and a lot of patients experience a kind of general feeling of unwell or malaise, which is just a general feeling of unwellness. So it didn't look too different initially. But interestingly, the changes in taste and smell, or anosmia, which have been reported a lot in other cases of COVID-19, weren't as prominent in our vasculitis patient cohort. Very few patients experienced any loss of taste or smell. And similarly, the disease complications that are associated with COVID-19 looked quite similar in our patients as well. Over 60% of patients experienced respiratory failure, which is damage to the lungs. And patients also experienced both low and high blood sugar, which Dr. Amy Malloy discussed last night too. So, so far, the disease doesn't look to be drastically different in vasculitis patients versus the general population. When we look then at the clinical outcomes that our patients experienced, the majority of this cohort did require hospitalization at some point during their COVID-19 infection, and the patients spent an average of 11 days in the hospital. 11.9% of these patients also required admission to the intensive care unit. When we looked at the types of clinical outcomes that patients experienced, 25 out of 65 patients did experience a critical outcome, which we had predefined at the start of the study as the requirement for advanced oxygen therapy, for invasive ventilation, or unfortunately death. So this is, we wanted to understand a little bit more about why this may be and why a greater number of these patients experience those outcomes too. So when we looked at all of the data that we'd collected, the clinical data, the immune data, we wanted to see what could kind of predict which types of patients would experience these more critical outcomes. And we found that respiratory disease, which is COPD, chronic obstructive pulmonary disease, or asthma, patients who had this as well as their vasculitis tended to fare a little worse, and this was confirmed by other groups as well. And also patients which had a low number of T cells in their blood at the time of infection. T cells are a type of immune cell involved in fighting infections. Patients who had low counts of these did in fact fare slightly worse. And also patients who were taking corticosteroids tended to have a worse outcome than those that were taking other immunosuppressive medications. And this is confirmed by another group from the Global Alliance of Rheumatology. But it's a little bit conflicting, the information that's available about corticosteroid use. Other studies have looked at corticosteroid use as a treatment for COVID, and they have found that patients who receive corticosteroids actually fare better. So in the red line here, you can see they have better clinical improvements than those who did not receive corticosteroids, and they have reduced mortality compared to patients who don't. And a recent meta-analysis was conducted where lots of different studies were pulled together to kind of compare all of the results as a whole, and they're represented by these different squares and diamonds. And you can see the results kind of lean towards favoring the use of steroids as opposed to not. So it's a little bit conflicting, this result, and a lot more work needs to be done to define why our patients fare slightly worse when they use corticosteroids as opposed to those who don't, because it's slightly different to what's seen in the literature. So to summarize our results, in our patient cohort, we looked at 65 COVID-positive ankylosing patients in the UK and Ireland. These incidence rates are actually lower than those that are reported in the general population, which shows that these patients were adhering to the kind of advanced procedures and taking more caution to reduce the rates of infection. Respiratory disease, corticosteroid use, and low T cell numbers were significantly associated with severe outcomes in ankylosing patients with COVID-19 infection. And as I said, we need to confirm a little more about the role of corticosteroid use. Then kind of the good news is that a lot of the other things that we did look at were not associated with worse outcomes. So there's no effect of the disease activity of vasculitis, whether it's active disease or remission. There's no one specific ankle subtype or non-ankle subtype that's more associated with poor outcomes, or any of the other background factors that we investigated as well. The next steps for us are to kind of delve a little bit deeper into the Irish cohort that we have, where we have very detailed immune profiles of these patients to understand a little bit more about how their immune system is changing and how that may play a role in the disease. And we'd also like to expand this Irish cohort into other rheumatic and inflammatory diseases. So the ORCID biobank is very strong. We have a large bank of samples there to work with, but we'd like to kind of look at other patients receiving the same medications, such as those with arthritis, psoriasis, lupus, and other inflammatory diseases to see if they're experiencing similar effects with COVID-19 infection. And we're actively working on that as well. That would be a lot better than kind of having more people contract COVID for the purposes of the study, which is useful though it would be, it's not what we want at all. So I'd like to thank everybody that's involved in this project. There's been a lot of hard work done very quickly by a lot of people that I really appreciate. In particular, the project for DeCOmPRESS and the research nurses who are the patient-facing faces that you would recognize. Dr. Matthew Rutherford and the UKVAS team for sharing this data with us so I could present it to you today. And of course, all the patients and donors and families who have donated to the ORCID biobank. This study absolutely would not be possible. We wouldn't know as much as we do without your donations and involvement in the project. So thank you very much for listening. I flew through that, but I'm happy to take any questions that people might have. Thank you.
That's great, Emma. Thank you so much.
Thank you.
It gives you a great overview to all the hard work you've been doing for the last, how many years? When did you start, you said?
My PhD started 3 years ago.
3 years.
And I've just been doing the COVID work since April.
I know.
Yeah.
So it's so important. I'll just put on my video, sorry now. So,
Here. Yeah, and I'm going to stress it again because probably the entire reason that we're able to study COVID-19 in vasculitis patients is because patients have been donating to the Rare Kidney Disease Biobank. So if that didn't exist, we wouldn't have the information that we do. And it really helps get everything off the ground very quickly when a lot of work needed to be done very fast. So thank you to all the patients who have donated to that biobank.
I think that's an important point to recognise, you know, that sometimes as patients you just sign up and you say, yes, I'll sign into the biobank or registry or whatever, but you may not really understand what's really the significance of it. So I think by you showing this is that was ready to go when it was needed, i.e. with COVID, with the DeCOmPRESS study. So it was because of that it was successfully funded, and you're able to work on this now and bring more research, not just for vasculitis, but I'm sure for autoimmune conditions across the board.
Yeah, absolutely. And now that we're looking to move into different groups of patients, such as arthritis and psoriasis, the ORCID biobank is like a template. They're all trying to replicate that for their patient populations. They want to do what we've done as well as we've done so that they can give that same level of care to their patients. That's
exactly, Emma. So that's it's even a broader base. I just see a question there. Seamus, is there a threshold level of steroids that increase COVID risk? I don't know if that's for you, or I've asked Mark to be online as well if there's anything. So I don't know who wants to take that.
I don't think we know the answer to that, Trish.
No.
I guess we will learn more and more as we go along, but at the moment, a lot of the research doesn't really stratify according to how much steroid.